Good afternoon. In the 15 minutes lecture series, we are going to see the important clinical problem a medicine resident or even an intern might encounter: hypercalcemia, high calcium in the blood. Treatment: what are all the drugs we can use? Because it is an emergency situation where heart can go for systolic arrest. The severe hypercalcemia, cardiac rhythm abnormalities can happen and it can be life threatening. What is it? Normal calcium level in the body is 8.5 to 10.4 milligram per deciliter. Any value above 10.5 can be called as mild hypercalcemia if it is below 12. 12 to 14 is moderate. More than 14 is severe. Why this classification important? Why we have to classify it into mild, moderate and severe? Because in mild cases, many a time patient might be asymptomatic. Treatment usually resolved without any much treatment. Why this mild happens? Most of the time by calcium supplementation. Whereas severe is having the life-threatening problems. So that is why the severity categorization is there. Mild, moderate and severe. So before going to the treatment, we should know what caused this. Why the patient landed in hypercalcemia. As we know, the calcium phosphorus metabolism is related to the two important hormone, IPTH, intact parathyroid hormone, and vitamin D. These are all the two main hormone which orchestrates the calcium phosphorus homeostasis in the body. So the hypercalcemia can be due to parathyroid related, PTH, parathyroid related, most commonly due to primary hyperparathyroidism. It can cause. It can be adenoma, it can be hyperplasia, it can be carcinoma. Mostly it can be parathyroid related. Or it can be non-parathyroid. Parathyroid is high, that is why calcium is high. On the other side, parathyroid is not high, but it can be due to high vitamin D. A high level of vitamin D. Mostly by supplements or some or other reason, vitamin D is high in the body. If these two are not there, then what else it could be? Commonly in medicine or nephrology, what we encounter is osteolysis, bone destruction, either by malignancy, a plasma cell disorder, or a fracture, crush injury. Tumor lysis. In tumor lysis, there is hypocalcemia, whereas in these situations, when the bone malignancy is there, bone is rapidly destroyed, calcium can be sometimes high. Mainly osteolysis. What caused it? First we have to know. As soon as the report comes, shall we jump into the treatment? First we have to guess what it could be. If patient is a case of CKD, most likely it may be a supplemented one or hyperparathyroidism. Secondary hyperparathyroidism can cause it. So overall, with respect to the etiology, we will see it in separate 15-minute series. In the treatment part, we should know whether it is PTH related, vitamin D related or other causes. Mostly hyperparathyroidism or the bone lysis can cause. Clinically, bone lysis we encounter as nephrologist. Okay. Vitamin D supplementation. In the clinical practice, which is the one we most commonly encounter for mild and moderate, it is the supplementation we will get. Okay. First we should know what caused it and going to the treatment. Before the treatment, we should know what are the things which can precipitate the hypercalcemia or which can act as a etiological factor. As I told, supplements, many a times bedridden patient, in a bedridden patient, calcium can be high in the blood. These are the precipitating factors. A patient might be on thiazide diuretics, drugs, multivitamins, sometimes calcium supplement. The trade name have to be checked. Even though we are starting the treatment, but these are the things which can precipitate or cause in a subtle way. A volume depleted. A subclinically volume depleted patient can have a mild to moderate amount of hypercalcemia. So these are the precipitating factor you have to keep in mind before starting the treatment. Treatment. What are all the options we have? Mild, as I told, mostly asymptomatic. We might not initiate the treatment. In moderate and severe, especially in severe. In severe, life-threatening situation, we have to start the treatment immediately, and these are all the options we are having. A hydration, calcitonin, bisphosphonate, denosumab, steroid, dialysis, and the etiology specific. One by one we will see. First, coming to the hydration. A volume depleted patient, excretion of calcium will be an issue for that patient. So the first and the foremost treatment is the volume replacement. We have to replace the volume. How much to replace depends on how much patient have lost it. If he is dehydrated, skin is dry, mouth is dry, we have to give a good amount of water. Minimum 2 to 3 liter can be required if he tolerates either oral or IV. Preferably IV. Preferably intravenous route. You have to make sure patient cardiovascular status is good. He can tolerate that amount of fluid. Monitor the pulse. Start the fluid at low rate. Start at 80 ml per hour, normal saline. Increase it to 100, 150, 200. If he tolerates the fluid, over how many hours we can increase? Over 3-4 hours, start increasing. If patient is already very sick, probably a wide bore cannula on both the sides might be required. This side you can start at 100, this side you can start at 100 ml per hour. At that rate, patient body will accumulate the volume. Once the volume gets accumulated in the body, the kidney can easily excrete calcium. As the blood flow to the kidney increases, the calcium excretion also increases. First and foremost, adequate hydration. This have to be continued. How to follow it up? If a patient is anuric, you can't give more fluid, so you have to follow it with the urine output. Patient vitally, check for the pulse, cardiovascular status, whether he is tolerating the fluid, check for the output and continue the hydration. Loop diuretic, yes, can be given only after patient is volumely replaced. If patient already volume depleted, you give loop diuretic, patient will land in AKI. Pre-renal AKI patient will land in. So make sure you are giving good hydration than giving a low dose of furosemide. Loop diuretic can be given because it increases the calcium in the urine. Is it recommended? Leave out the recommendation and all. Furosemide as such, it is not clearly recommended. The main treatment is hydration. If adequately hydrated, yes, furosemide can be given. Previously, alkaline diuresis and all, they name it, but currently adequate isotonic saline replacement with a low dose of furosemide can be given. First and the foremost step for the MD medicine resident. First year, admit the patient, give hydration. After 3-4 hours, the patient is adequately hydrated, give a low dose of Lasix. Considering the patient urea creatinine value, you have to decide on this. If patient cardiovascular system is compromised, you can't jump and give the fluid, patient cardiovascular system will deteriorate. CCF patient and all, you have to put the patient at 45-degree angle, then 45-degree angle with continuous cardiac monitoring, fluid have to be titrated accordingly. This is the first and the foremost step where the patient can be prevented from arrhythmia. Next, calcitonin. It can be given in the subcutaneous or intramuscular route. Nasal spray is also available. The unit is 4 units per kg can be given. Whenever we are using this, the calcium have to be repeated every 6 to 8 hourly to make sure patient calcium is not fluctuating grossly. This acts by 3 important mechanisms. I hope you might be familiar. Kidney, it prevents the reabsorption. Gut prevents the absorption. Osteoclast, it prevents from acting so that the bone lysis will come down. Calcitonin, injection calcitonin, it also effectively acts. Fast acting. So isotonic saline and calcitonin. Do we start calcitonin in all the patient? Isotonic saline, most of the time it brings the value down. If not, Calcitonin, a very high value with ECG changes. Preferably, we have to buy this. Calcitonin injection you can give as a, if available, nasal spray can be used, otherwise subcutaneous route. The second one is calcitonin. So as I told, it inhibits absorption from the gut, from the kidney, and inhibits the osteoclasts. This is the mechanism, injection calcitonin. Then comes the most important one, primarily for the bone resorption part. Even if the patient etiology, at the time of emergency we are not knowing the etiology, still it can be used. Zoledronic acid at a dose of 4 mg, pamidronate at the dose of 60 mg. These two are IV. The oral formulation is ibandronate. 150 mg can be given. One catch is there. Patient kidney should be functioning normally because this is being excreted through kidney. If eGFR is not good, what will happen? It will get accumulated in the body. It will cause toxicity. So bisphosphonates can cause toxicity in a patient with less eGFR. The risk and benefit have to be decided. Suppose patient KFT, suppose patient eGFR exactly we will take 30. During that time, what decision to take? If kidney is borderline 45 GFR 45 ml per minute to 30, even up to 25, the clinical decision can be taken. Bisphosphonates can be given at a half dose if required. The risk and benefit. What is the risk of giving bisphosphonate? What is the benefit of giving bisphosphonates? If calcitonin is not available, in some centers you might not get calcitonin. If bisphosphonates is available in the half dose, you can give because we have to save the patient from life-threatening arrhythmia. Bisphosphonates can accumulate and can cause toxicity, but at least it acts during the particular short interval. Bisphosphonates, as you know, it inhibits the bone resorption. Osteoclastic resorption is being inhibited by the bisphosphonates. Only catch is it is contraindicated if eGFR is less than 30. 30 is for theoretical purpose. As we go towards CKD 4, 5, 3B onwards, be cautious. If the situation warrants, half dose can be given. IV is preferred rather than the oral route. The rank L ligand antibody, Denosumab, is a rank L antagonist, can be given as a subcutaneous route, 60 mg. It can be given even in a renal dysfunction patient. Injection, you might have used it in osteoporosis once, at least till the time we are finding the etiology of hypercalcemia. This can be used. Suppose if there is a clear-cut evidence of bone lysis, multiple injection might be required after 2 weeks. As per the Harrison, the schedule is this. Twice weekly can also be planned, once monthly, but initially we have to stabilize. A maintenance dose of this drug might be required. Denosumab, very very important drug. In situation where calcitonin is not available, this drug mostly will be available. Mostly if there is ortho department, definitely this injection will be available. If calcitonin is not there, we are not having option of bisphosphonate, yes, this drug can be used. Then comes the most important one, steroids. The role of steroid is in inhibiting any inflammatory or autoimmune thing. Whenever there is a granulomatous disease or vitamin D production, it inhibits the active form of vitamin D being formed, especially useful in granulomatous diseases causing high vitamin D, causing hypercalcemia. Steroids might be required. Ongoing inflammation, to reduce it also, steroids are required. Prednisolone can be started at 40 to 60 mg. 1 mg per kg is high dose, or 0.5 mg per kg per day can be started on condition that patient is not in sepsis. As I told, we have to find the etiology. Even though we are not getting the etiology, a stat dose of steroid can be given because the particular osteolysis, that granulomatous thing is there. Even if Denosumab or any of the drug is not available, a steroid can be tried because it inhibits that vitamin D generation. If it is of other etiology, then also the surrounding inflammation, autoimmune related etiology can be bit reduced. Till the time we are finding the etiology, yes, steroids can be given, especially in sarcoidosis type of thing, granulomatous type of etiology, steroids being used in managing the hypercalcemia. The most effective immediate correction of the calcium. Immediate correction of the calcium is by hemodialysis. Peritoneal dialysis not that effective. If value is high, ECG changes is there, even urea creatinine is normal, adequate hydration is given, 8 hours we waited, no change, take for dialysis. Patient is at high risk of cardiac arrest, take immediately up for dialysis. When to use this dialysis? When we are giving hydration, Lasix, no response, can be taken. Very high value, 16 milligram, 17 milligram, very rare, you might not have seen. In case if these values are extremely rare and more common with the bone osteolysis, tumor, plasma cell disorder, very common. That time hemodialysis can be taken. Short-term treatment, not for long-term. Immediately it can bring the calcium down. We have to use less dialysate in the dialysate side. In the dialysate bath, we have to use a low calcium one. Peritoneal dialysis is effective in the hemodialysis. Coming to the etiology specific, this side we have seen hemodialysis. Etiology specific, if it is parathyroid related problem, adenoma and all, parathyroid have to be removed or surgery might be required. Parathyroid malignancy surgery might be required. Calcimimetic agent, hyperparathyroidism, calcimimetic agent. What is the calcimimetic agent? Cinacalcet, can be cinacalcet. How it acts? It increases the sensitivity of receptor to the calcium. So cinacalcet can be given if it is hyperparathyroidism, high parathyroid hormone in the blood, etiology specific where surgery is not indicated. Yes, calcimimetic drugs, cinacalcet 30 mg per day serially can be increased to 60 mg, 90 mg can be given if it is due to parathyroid related. And we have to treat the etiology, what it caused. If it is a vitamin D injection which is causing, that have to be stopped. Plasma cell disorder, that have to be treated. And this is a summary of the treatment option we have seen. How fast it can act. Because in hypercalcemia, severe, especially severe I am saying, higher the value, faster to be acted, because there is a risk of arrhythmia. Whenever risk of arrhythmia is there, act fast, otherwise patient might collapse. So hydration and loop diuretic, immediate the action might be, because as soon as the hydration increases, the renal excretion of calcium increases. Calcitonin, even though DAX immediately, probably within 2 days, the action might last. Subsequent injection might be required. For the bisphosphonates to act by inhibiting the osteoclast and to stabilize the calcium might take 3 days. Denosumab might be taking longer hours, might be 4 to 10 days. Steroids again to stabilize the vitamin D, it might take another 3 to 4 days. Dialysis immediate. So what are the two things we have to focus on? For immediate thing, hydration. Dialysis if required. Cinacalcet, surgery. These are all the options. Most of the times getting calcitonin might be difficult. Bisphosphonate, denosumab, steroids were always the option. I hope medicine PGs or medicine resident who's watching this video, I hope you might be knowing what are the treatment options. Now, get the ECG, try to probably figure the etiology treatment we discussed. In the follow-up video, we'll discuss the etiology. If you have any doubt related to this, you can comment, we'll discuss soon. Bye-bye.